So, dear colleagues, very good evening to all of you. First, I appreciate the TNIPS Subcommittee Committee for promptly organizing this Enrich Webinar almost for the past 3 months on every second Tuesday from 8 to 9 p.m. The main objective of this webinar is to provide an opportunity for our young psychiatrists to share their knowledge with our colleagues. Very young and eminent speakers, Dr. Helena, Selvakodi, and Dr. Divya. Both are going to speak about a very useful topic on current trends in child and adolescent practice. And also another speaker, Dr. Divya, is going to speak about suicide risk assessment in primary care settings. So I think both will be useful for the practitioners here and all the consultants. 2 minutes over to you. So I will give it to this session to our moderator, Dr. Arulvarman.
Thank you, sir. I am audible, sir?
Yes.
Okay. I welcome all for this Enrich Webinar. I welcome Chairperson Dr. Sivabalan Ilangovan, who is Professor and HOD of Psychiatry, Biopsychosocial Medical College and Hospital, Coimbatore, Chennai. We have 2 speakers. First one is Dr. Selvakodi, who is currently working as satellite clinical psychiatrist under DMHP in Coimbatore. She got her DPM from Madurai Medical College in 2019. And her area of interest is child and adolescent psychiatry, as evidenced by her having undergone somewhere in child abuse course in MATS. The second speaker will be Dr. Divya, who is currently working as assistant surgeon, Government Headquarters Hospital, Walajabad. She obtained her MD Psychiatry from Madras Medical College in 2022. And she worked in Telangana as consultant for Tamilnadu State in 2022. Her area of interest is mood and anxiety disorders. I welcome you all, and I hope we stick to the time. Yes, let's start. Over to Chairperson, sir.
So good evening, one and all. First of all, I thank TNIPS and Dr. Panneerselvam sir and Dr. P.P. Ganam sir for giving me this opportunity. And I thank moderator Arulvarman also, and I invite 2 eminent and young speakers of today, Helena and Dr. Divya. So regarding this topic, the current psychiatric practice is completely different from olden days in many ways, I guess. One of the important changes, now the psychiatry is moving towards preventive aspects. That is very important development as far as psychiatry is concerned, I guess, because once we thought there was no treatment for mental illness, there are so much of the pseudo-scientific and religious treatment. After the development of so much of the psychiatric advancement, not only we are treating the psychiatric illness, now we are coming into the point we think about how to prevent all the mental illness. That is very important development in psychiatry. Once we think about the prevention, then naturally the population of interest will be a child and adolescent, because Suresh Sir always used to say, now there is a paradigm shift in psychiatry that we are focused more on the child and adolescent population in order to prevent the major mental illness in adulthood groups. So in that aspect, this particular important topic, the first topic, the second one also is very important, because so far we are always assessing the suicide and risk and intent only those people who attempted suicide. Now the prevention of suicide, it is completely moving towards the community ones. Because once we going towards the community, then only we can completely prevent suicide in all the population. So in primary care level, how do we assess the suicidal risk? That is very important. We have to train so much of the medical and paramedical profession in those the primary care area. So that is the second topic. So I am also waiting for the speaker to giving some light on these 2 important topics. I welcome the first speaker, Dr. Helena, to present the topic. Thank you.
Good evening all, and especially on this grand evening, I thank our respected IPS President Dr. Panneerselvam sir and moderator Dr. Arulvarman sir for giving me this opportunity, and also thank other scientific committee members of IPS TamilNadu Chapter. And today, this session, I have divided the session into 4 parts. First, mainly focusing on about the child psychology, how it understands any psychological issues which undergoing inside the child. And the second thing about the biopsychosocial grid, how we can put the grid into by identifying the child's issues from getting into psychiatric illness. And third thing about the current trends undergoing in research will be focusing on how to prevent the child from getting into the psychiatric illness. We go one by one. First, we should know about the basis of the children's emotion and behavioral issues. For that, we can have a framework of analysis. It includes 5 things. First, context, then experience, the inner voice, emotions, and the behavior. First, we should understand on what context the child is experiencing the illness. That is, we should know the child's location and the living arrangements or the family situation from where the primary experience of the child comes from. Second thing, what the child experience, either the physical neglect or emotional neglect or any separation from the loved ones or any death in family recently, or any sexual abuse, verbal abuse, emotional abuse. Then third thing, we should focus on the inner voice of the child, what it thinks. It may think that I am damaged, I am powerless, I am responsible for what happened to me, and it is because of my fault. And the fourth thing is the emotion. So because of the thought, what the child thinks inside, because of that, the child try to give some emotions like, for example, for thinking that I am damaged and thinking of powerless, the child will feel like frustrated and hopelessness, which will lead to anger. So the fifth thing is the behavior part. So because of the response to the emotions, the children try to hit someone or throw something or cry, or it become very calm with social isolation, avoiding by being social isolated, not engaging socially. So this is the basis of a children's emotion and behavioral issues. So based on the context, the child will experience and it will undergo some inner voice. And because of the inner voice, the child will have some emotions. And because of the emotions, the child will behave like hitting someone or something, or by crying or being anger or sadness. Then second thing, what are the things the children needs from us, from the family, from the community when it's growing up? That is the 6 needs of the children. One is the need for love. They want to be loved for what they are than what they do. We should avoid comparing them with anyone else, and we should also give them opportunities to love others. Second thing is the need for security. This is the basic thing for each and every child. Here, we should understand the things in their point of view. Third thing, the need for significance. Here, they want to be noticed always. We should ask their opinion. We should discuss with them. In each and every decision-making things, we have to ask them. We should discuss with them. We should ask their opinion. And fourth thing is the need for praise. And here we should praise the kids very sincerely and realistically. And here we should avoid the unnecessary scoldings to the children. And fifth one is the need for acceptance. We should train them that all the mistakes can be forgiven. So the children also will learn to accept their own mistakes. The sixth thing is the need for discipline. We should mold them with discipline, not by nagging or pestering or forcing, only with the path of patience. We should mold them with the discipline. So these are the 3 needs of the children needed in their childhood age. Then, because of the family, how they are brought up, the children are differentiated in 7 roles. They get 7 roles in each family. Each and every children, either one children will be like a hero or heroine, that is they'll be very good, talented, very happy, they will not fail at all, they need not any help from anyone. But another child will be called as enabler. this child always used to care about others because of the family situation. These 7 roles will be recognized in each and every family. The enabled child will be very responsible. It will always reach out to others. Even they didn't ask any help, it won't interfere with others' issues. And they want appreciation. If they doesn't get that appreciation, then they will start blaming others. Then the pleaser children. These pleaser children, always they are here to help others. Always the parent will ask them to kindly sacrifice this one for your brother, for your sister. Your parent will always target specific children. So they are called as pleaser. Here they are very adjustable. They are peacemakers. They neglect themselves, their health, and they will not make any decisions properly. And the fourth type of children is the clown. Here the clown, here they will always distract the real thing, and they always blame the other people. And if they want sometimes take their opinions serious, but it will not occur always. They will be their opinions are not taken as serious, so they will get hurt. And fifth type of children is the scapegoat. Here they are very smart and intelligent, and they will identify the problem quickly in the family, and they will stand for the others in schools and colleges, or they will stand for others if they are in issues, and they bear unnecessary problem upon themselves. And so they always get into problematic relationships, and sometimes they are very become bitter and disliked by others. And the another type of children is that is invisible child. These children will be not considered in the family always. The children itself will be very alone, very isolated. It will not disturb others, and it will not take any care and responsibility in home. And the last child is the little spouse. Here there are few children in few families that they will take the care of the charge of their parent, as they have any dysfunctional families, any single parent or no parent. The child will become very mature beyond their age, and they're very hardworking, responsible, and take charge of the family, and they'll miss their childhood. That's truly speaking, and they're very hard worker, and always they end up in failures. And the second slide is this slide denotes about the biopsychosocial grid model. How we can make a child into this model and getting into conclusion of getting into a psychiatric illness or not. We are well known that the biopsychosocial factors which are responsible for the child psychiatric illness, or regarding biological means, we can think of any genetic issues or any neurotransmitter imbalance, or any disease, or any infections, or any genetic mutation. All other causes for these are the biological cause for the getting into psychiatric illness. And the psychological cause are the personality issues, decreased coping skills, or decreased resilience, or any insecure feel, and poor decision-making skills, like that. Then social factors are living in dysfunctional families, or without living in a single parent, or abandoned child, or lost parent in any disaster. So this type of biopsychosocial factors always plays a role. Apart from that, we have to frame their biopsychosocial factors into all the 4 P factor model too. That is the predisposing, precipitating, and perpetuating and protective factor. The predisposing factors are already having the genetic vulnerability, and the personality trait, or any sexual assault, like that in society. The precipitating factors are like taking a substance now, and or any recent loss of, or being abandoned in a family. And in social cause, or any loss of home, or loss of relationship. Then the perpetuating factors are having any severe chronic pain, taking a lot medication for a long time, or having decreased coping mechanisms because of the personality, and having a very poor financial status. Then apart from all these predisposing, precipitating, perpetuating factor for causing you into psychiatric illness, only one thing will help the child from getting into, from not getting into the illness. That is the protective factor. That we should always focus on the each and every child. We should know about their adequate diet, either they're taking or sleep, or their resilience, intelligence, their cognitive status, behavior styles and coping styles, and either they have any family support, both financially or emotionally. So these are the protecting factors which will help the child from getting into psychiatric illness. Now, the second part of the session is that is the current trends regarding the prevalence epidemiology. In India, a lot of prevalence study has undergone. For example, in Lucknow, they found that the camp disorders is 12.1%. In Bangalore, it is 12.5%. And in Tamil Nadu, it has found as 33.7%. It is very high in Tamil Nadu. Then by seeing each and every psychiatric illness, we'll get into the current trends inside each subheading. That is, regarding the prevalence, the WHO, World Health Organization, has given a prevalence study of autism spectrum disorder as 1.6%. all over the world. And the new research going on autism spectrum disorder, or the brain inflammation has effect in causing autism and schizophrenia in children. And another study is regarding the melatonin. The melatonin also shows very good effective in for sleep disturbances when given for more than 50% of autism children. Then the third thing is the suramin. That is the suramin based on Brain Foundation. It was under trial in 2017, and now it is accepted as for giving improvement in the domains of language, social interaction, and repetitive behaviors. And the fourth one is, it is now on trial, that is the AB 2004. It is a main gut absorbent. Usually it will decrease the gut metabolites. And regarding the treatment, SSRIs, atomoxetine, risperidone is already known, but the recent thing is loxapine has been tried. And and also the deep brain stimulation also holds a good outcome by targeting the deep brain parts to provide the external generator focal electrical neural network for modulations. Then the psychosocial therapies undergone in autism spectrum disorder, that is mainly the applied behavioral analysis. It is in current work, and it is based on the theories on learning and operant conditioning. It includes the specific interventions targets that is coupled with positive reinforcement, that is mainly on verbal praise, tokens, edible rewards with repetitive of learning. Regarding ADHD, regarding the prevalence, in 10 to 14 years of children, we can find 3.1% of ADHD, and in 15 to 19 years, it is 2.4%. And regarding the management, the psychostimulants methylphenidate, that is called Jornib PM, and Asprise, that is a combination of serdexmethorphan plus dexmethorphan for patients aged 6 and older. And Adderall and Vinus always contains mostly of the amphetamine. And in 2023, Zellstream, it is the new ADHD stimulation patch have been aroused, and Kelbray is the non-stimulant given for age 6 to 17 years. And another one is atomoxetine. And then the non-pharmacological management tried in ADHD are the behavioral therapy and CBT. Regarding conduct disorder, prevalence, that is 4.58%, common in boys, and a lot of studies has undergone. SF found as 0.9%, Kashmir as 8.7%, and WHO given as 3.6% for 10 to 14 years of children, and 2.4% for 15 to 19 years of children. Indian studies has undergone, that is by Divya Sigamani, and he reported the prevalence of conduct disorder as 11.13%, and Sarkar as 7.1%, and Srinath as a low 0.2%. And another studies has undergone that because of the viral encephalitis, the hyperactivity and oppositional behavior aroused. And another thing is that is specified, there is LPE, that is limited pro-social emotion specifier. It is found in conduct disorder, and in a 10-year longitudinal study in juveniles of residential care. And regarding the conduct disorder on non-pharmacological management, there are various studies has undergone by George Jordan. That is, he found that the social competency, individualized social competency therapy than group therapy can reduce the aggressive behavior. And Kurtzon et al. Found that the group behavioral skill training program that is called Start Now, it is given for female adolescents with the with the oppositional defiant disorder and conduct disorder. It is worked well. And Jorgens and Manger, they found that the parent management training is beneficial. And the Cochrane review found that by Furlong et al. That the behavioral and CBT group parent programs are more effective for conduct disorders patients. Then the Van de Well et al. 2002 meta-analysis found that the parent management training and CBT for children given positive outcome in conduct disorder. The other pharmacological managements are in 2000, it was found that by finding et al., it is found that risperidone was superior in reducing aggression, and Pringzim et al. Found that the psychostimulants shows larger effect on symptom regulation and atomoxetine on reducing aggression in ADHD with CD, with conduct disorder. Corner et al. Found that clonidine has moderate effect size on symptoms of ADHD with conduct disorder. And few other drugs are also used. There is risperidone and ivalprox and Ritalin. Regarding the childhood anxiety and depression, the SCARF study in India found that 30% of students suffer from anxiety and depression. WHO prevalence study shows that anxiety disorder is 3.6% in 10 to 14 years and 4.6% in 15 to 19 years. In depression, 1.1% of 10 to 14 years and 2.8% in 15 to 19 years. UNESCO report on 2008 found that India is the home to 25.3 crore adolescents. Among that, 14.5% are with depression and 24.9% are with anxiety. Then regarding treatment for anxiety, SSRI, fluoxetine 10 milligram up to 60 is used, and sertraline 25 to 200 milligram can be used, and duloxetine 30 to 120 milligram can be used for children. And vortioxetine and guanfacine recently used. Regarding the therapies, CBT and interpersonal therapy for generalized anxiety disorder and social anxiety disorder, and social affective therapy, especially for children, is used for social anxiety disorder, and acceptance and commitment therapy for generalized anxiety disorders are tried. And treatment for depression, escitalopram, fluoxetine, duloxetine are used. And regarding food supplements, omega-3 fatty acids, probiotics, vitamin D, folate are used. And a few, then the deep TMS also used. And the new drug that is gepirone, that is gepirone is used for adults, but not found for, still no, not confirmed for children. It is a serotonin 1A receptor for mood and emotional regulation. Regarding the National Mental Health Survey of India, we can find that Tamil Nadu and Jharkhand holds the highest place for depressive disorder in 2015 to 2016 survey. And regarding the substance abuse, the Rajkumar Bansal found that out of 300 child laborers from 6 slums in Surat, 45% are with substance abuse. And majority is tobacco smoking, then followed by cannabis, opium. Regarding the childhood sexual abuse, how it affects the adult survivors. Regarding that, Varsha found in her study found that reported that the Children's Hospital, that is in Los Angeles, found that before 6 years of age, half of the survivors had sexual abuse. And particularly for more than 1 year, 84% of the survivors have been affected. And for more than 10 years of abuse suffered by the 40% of the survivors. According to the NCRB National Crime Reports Bureau, this has been found that 36.5% of cases are against children under POCSO. And among them, 53,276 are girls and 1,083 are boys. And there are a few helpline numbers for children in government side, that is 1098, and women helpline number is 181. We may it may get access to through that, and may get safe from the strategy any problematic situations. And these children who are secured through this 1098 by the control room, they are being kept in a very safe places, like in observation home, or in juvenile home, or in safer places, and there their mental issues have been screened, and treatment is started by the DMHP psychiatrist. Then regarding the suicide, Sharma reported that in the study, 15.8% adolescents in South India with suicidal thoughts and 5.1% with attempted suicide. And according to the National Crime Records Bureau and accidental deaths and suicide in India, it has been found that every day 35 students are dying by suicide in India. And also the Mental Health Care Act 2017 was aims at decriminalizing the attempt to die by suicide, thereby ensuring that the individuals are given opportunities for rehabilitation than being punished. And the state helpline number are 14416. 14416, that is Natpuram Ungaloda, and 104 suicide helpline number. And other recent research updates on somnambulism is for treatment purpose, we can use low-dose benzodiazepine and trazodone. And for skin picking, we can use fluoxetine. It has given a good outcome. And in trichotillomania, insight-oriented psychotherapy and cognitive behavioral therapy are very effective in treatment. And Critchley and Hoffman found that in Klein-Lewin syndrome, that periodic attacks of excessive sleep and eating, and there is one more variant, there is unusual variant of Hallermann-Streiff syndrome. They found psychosis along with a chromosomal anomaly and a mandibulo-oculodyscephaly. And clozapine, when used in pregnancy, it also leads to agranulocytosis in fetus and neonate. And regarding the childhood-onset schizophrenia, it has been found that the investigation expectant and neurophysiological findings shows greater temporal lobe involvement, and Mute found that 3q29 deletion syndrome, which shows 40-fold increase in development of schizophrenia. And another thing is the DiGeorge syndrome, that is 22q11 deletion syndrome. And in regarding treatment below 13 and older, we can use second generation antipsychotics like aripiprazole, urazidone, olanzapine, quetiapine, and risperidone. And for 12-year children, we can use paliperidone. And the first generation antipsychotics, there only limited things used, that is perfenazine and thiotixin for age 12. Other psychotherapies are individual therapy, family therapy, life skill training, and vocational rehabilitation. And regarding the bipolar in juvenile, the meta-analysis showed that the prevalence is 3.9, double the thing got from the 2011 meta-analysis, that is 1.8%. Regarding therapy, the focusing on the family-focused therapy, CBT, and IPSRT, that is interpersonal and social rhythm therapy. Regarding treatment, the FDA approved the risperidone in 2007 for 10 to 17-year-old, and olanzapine for 13 to 17-year-old, and aripiprazole for 10 to 17-year-old, and quetiapine for 10 to 17 years of children. And regarding the clozapine is also tried with 200 milligrams within 4 weeks. And in a systemic review, it is found that the lamotrigine is also used as augmenting or monotherapy agents. And mainly the mood stabilizers used are divalprox, lithium, topiramate, and oxcarbazepine. Mainly the mother and child interactions is mainly for the cause of borderline personality. And later on a treatment purpose, in treatment, it is come to understand that a lot of issues has been under because of the attachment issues and because of the mother and child interactions, because of the dysfunctional families, the issues they have gone through. And this is the one coming in upcoming days. This is the neurofeedback therapy. It has been used for autism and for normalizing of the sleep in insomnia, for improving cognitive function, and for Parkinson's, Alzheimer's, migraines, OCD, and to improve the emotional affect regulation, for conduct disorder, for pain. And one study, there is a Monestro study that is regarding the ADHD and biofeedback versus a stimulant alone. When they tried, they found that the patient did not sustain the gains when Ritalin is removed, stimulant is alone removed. But they can able to sustain their gains even Ritalin is removed in the presence of EEG biofeedback. So this biofeedback is nowadays playing a role in for mainly for the ADHD, for autism, for the pervasive developmental disorders. And a lot of therapies have been given, and family therapy, and we have to focus on the budget, the mental health budget given for India when compared to other countries is very low. So that should be focused, and the policy also should be reframed, and a lot of camp courses should be conducted to encourage the to make a skill in to make the mental health professionals in skillful in handling the child and adolescent mental health issues. And the WHO has started that helping adolescent to thrive initiative. There is HAT and MH Gap Intervention Guide 2.0, mainly for giving assessment and management of mental health conditions in non-specialist care settings. And a lot of research are undergoing, that is with ICMR. ICMR combined with Medical Research Council UK, they have undergoing CVEDA and another longitudinal studies undergoing that influence the behavioral and cognitive outcomes in children and families over time. Mainly they focus on prenatal and parental and caregiving environment and developmental processes which cause the issues in children. Thank you, sir.
Thank you, ma'am. Next speaker.
Yes. So I would like to thank all the esteemed teachers and professors of this platform for giving this opportunity. My topic is current trends in suicide risk assessment and primary care setting. So this is the overview. We'll first briefly view the statistics, primary care and its role in suicide prevention, screening for suicide risk assessment, dispositional plan, followed by risk formulation, government telehealth services, national suicide prevention strategy, and carry home message. So briefly revisiting the statistics to understand the significance of the role of primary care. The NCRB has reported 1,64,000 odd suicides in 2021, which has been an increase of 7.2% compared to 2020. And the rate has also increased. There is 12 lakh per population compared to 2020. And this has been the highest ever recorded since 1967, when the NCRB started reporting the suicides in the country. Maharashtra tops the list, followed by Tamil Nadu, Madhya Pradesh, West Bengal, and Karnataka, and which contribute to 50% of the total suicides reported in the country. In terms of rates of suicide, Andaman and Nicobar Islands reported the highest rate, followed by Sikkim, Puducherry, Telangana, and Kerala. And family problems and illnesses contributed to the highest risk factors for suicide. And male to female ratio has seen a rise since 2020, and which was probably attributed to the rising unemployment and economic downslide following the pandemic. And males bore the much brunt of the economic debacle, which was characterized by pay cuts, interruption of payment, and loss of jobs. Daily wage earners, followed by self-employed persons, were worst hit. And even among female suicide victims, daily wage earners constituted the third position. And among the suicide victims in the farming sector, 50% was constituted by agricultural laborers. And in females, marriage-related issues, specifically dowry-related issues, were the highest contributory factors. And among women, homemakers were more among the victims. Gender inequality and dowry practices continue to make marriage stressful to Indian women rather than protective, as portrayed by Western studies. And among the age groups, 18 to less than 30 years contributed to 34%, and 30 to less than 45 years contributed to 31% of the suicides. And a significant proportion of the victims were students too, and 13,039 students were reported to have committed suicide in the year 2020. And when observing the pattern in economic status, we see that the annual income of less than 1 lakh per annum showed a consistent correlation with suicide rates, and 64% of suicides were reported in those from that sector. So this is the graphical representation of the suicide rates from 1967, when the NCRB was incepted, till 2018, and now it is 12 lakh per population, which is the highest since 1967. And this is the profession-wise distribution, where we see that the daily wage earners constituted a significant proportion, followed by housewife and self-employed persons. So why do we need primary care? And what is the role of primary care in suicide prevention? So primary care physicians form the frontline care providers in the healthcare system, and they form the first level of contact between individuals and families with the health system. And in India, primary care is delivered through sub-centers and primary health centers in rural areas, whereas in urban areas, it is provided through health posts and family welfare centers. So what is the role of primary healthcare in suicide prevention? So from various studies, it was observed that the contact with primary healthcare was highest in the year prior to suicide. An average contact rate of almost 80% was observed. And at 1 month, the average rate was 44%. The lifetime contact rate for mental health care was 57% and 31% in the final 12 months. So 31% of people contacting the mental health care in the year preceding suicide, compared to 80% of people contacting the primary health care in the year prior to suicide, which makes primary health care the optimal platform to screen patients for suicide. And women and those over 50 years of age had the highest rates of contact with healthcare prior to suicide. So currently, the shift has been from prediction to therapeutic assessment, formulation, and risk management. So screening in primary care setting provides us a valuable opportunity to identify individuals at risk and intervene. And it is an ideal venue because we can link the patients to the care and supports they need. What is the perception of people towards screening for suicide in the primary care? From various studies, it was observed that 96% of the population believe that primary care providers should screen patients for suicide. And 91% of the patients rated the actual screening process as neutral or positive, and only 9% rated the experience negatively, and that too for fears that they would be judged negatively or that the screening questions made them uncomfortable. So I would like to show a pictorial representation from a book, Suicides Beyond Numbers, published by Nemhans in 2001. Where it shows the trajectory of an individual towards suicide. So where we see the predisposing socioeconomic factors, psychological factors, and the person who was from a middle-class family developing a chronic leg pain, increase in pain, and accessing primary health care, no relief with treatment, and cognitive symptoms, followed by chest pain and functional impairment, finally ending up with the suicidal attempt. So in primary care, we aim to intervene the patient at early stages, thus preventing the patient from advancing into the severity spectrum of suicide. This is another pictorial representation where we can see the constant liaison between the primary care physicians and the psychiatrist can help develop a better rapport with the patient and help the patient seek psychiatric care and mental health care as early as possible. So the patients who are at the primary care level, they are in constant touch with the primary care physicians. So they are at an optimal position to identify patients who are at risk, who might show warning signs, and decide who needs immediate referral to the psychiatrist, and whom they might even be able to provide the basic care, and thus this lessens the lead time to mental health care. And suicide risk assessment requires a culturally informed assessment. And why is culturally informed assessment important? Because each community has its own cultural scripts for suicide. And we should understand if that particular community has any special traditional suicidal behaviors. We should explore the meaning of suicide from the patient's cultural point of view, whether they consider it an art of sacrifice, a social statement, or an attempt to end personal suffering. And we need to avoid projecting our own value system onto the patient, and understanding the cultural context of help-seeking behavior is equally important. These are some of the terminologies used in suicidal risk assessment. And of these, suicidal ideation, suicidal intent, and plan are very important. Suicidal ideation means the thoughts of engaging in suicide-related behavior. Suicidal intent is when there is evidence that at the time of injury, the individual intended to kill himself or wished to die, and he understood the probable consequences of his or her actions. And a plan is a thought regarding a self-initiated action that facilitates a self-harming behavior or a suicidal attempt. So we need clinical pathways to guide screening for suicide and assessment in primary care. And one such clinical pathway was established by National Institute of Mental Health in 2017, which outlines the following steps. So first step is suicide risk screening, followed by risk assessment or brief suicide safety assessment, and followed by disposition and plan. So prior to implementation of such clinical pathways, it is very pertinent to educate and train the primary healthcare professionals and organize referrals. So the referrals can be either the patient's own mental health provider or an on-site behavioral health provider, or a local crisis center or a crisis hotline, and if there is no other option, the emergency department. We need to establish a list of outpatient mental health providers or agencies in that locality to facilitate easy and early referral. We need to connect with them and inform them prior if we are going to screen the population for suicide to learn if they can accommodate patients who screen positive. And if there are no other options, telehealth alternatives may also be considered. So screening is a rapid method to identify who needs further assessment. So it can be done either through verbal interview or a self-reported paper or pencil form or computerized instruments. The screening tool should have strong sensitivity and specificity to minimize false negatives and false positives. So when, where, and whom to screen. New and existing patients who can answer questions should be screened. They should be screened if they are new to the practice, or if they have not been screened in the past 12 months, if they have had a positive suicide risk screen in the past 12 months, or if they have a current psychiatric diagnosis or clinically significant substance abuse. Where to screen? It should be screened in privacy, and it is optimal to incorporate suicide risk screening into other routine screening processes such as the vital assessment or mental health questionnaires. So this is to reduce the stigmatization. And when to screen? Existing patients should be screened at the next available visit, though there are no practical guidelines or consensus guidelines on the frequency of screening procedures. At least once a year is considered best practice. What if the patient refuses to complete the screening? They are free to do so, but we should document it in the healthcare record and re-offer screening at the next visit. 95% of the screening outcomes are negative and no further action are required, but we should still watch for potential signs of suicide in that person during further visits. So these are some of the screening tools. There are many tools available, but these three tools are easily available and they can be applied to patients in primary care. One is the Ask Suicide Screening Question Toolkit by National Institute of Mental Health, Columbia Suicide Severity Rating Scale, and Patient Health Questionnaire 9. So this is the Ask Suicide Screening Questions. This is the Columbia Suicidal Severity Rating Scale, and this is the PHQ. This PHQ item 9 is very important because it directly inquires the patient about suicidal ideations, thoughts that the person would feel better off dead or hurting himself in some way. So whether depression screening can be used as a substitute for suicide screening? No, it is inadequate and it has to be used in conjunction with suicide risk screening. PHQ item 9 alone cannot be used to screen for suicide because some studies have identified that 1/4 of the suicide attempts had occurred within a week of the patients completing the PHQ, and especially when they have answered not at all. That is when they had no risk when assessing the item 9. So whether it was because they had not experienced suicidal thoughts at the time of the visit, or they had underreported or misinterpreted the questions, we are not sure. So this is the graphical representation of the cumulative risk of suicide following PHQ item 9 response. So of those persons who had responded not at all, which means they didn't harbor any suicidal ideations. They had reported not having had any suicidal ideations during assessment. In the year following completion of the PHQ questionnaire, a proportion of them still committed suicide. And among those who had suicidal ideations, nearly every day, majority of them committed suicide. So how to manage patients who screen positive? So further, we'll be going into risk assessment. Not every patient with suicidal thoughts is an emergency. Most patients with suicidal thoughts detected in our practice will not need emergency measures, but we should triage and see who is at high or imminent risk and should employ full safety precautions like constant observation or transfer the patient to mental health professional or the crisis center or the emergency department. So going to risk assessment. Risk assessment is to, the purpose of risk assessment is for immediate triage to determine if the individual requires immediate attention or same-day evaluation by a behavioral health provider or connection with a crisis center or an appointment with a outpatient behavioral health provider within 7 days. So its whole purpose is to decide whether a full mental health evaluation is needed and if so, how urgently. And these are the key principles of suicide risk assessment. It is a part of therapy and it occurs in the context of a therapeutic relationship. It should be unique for each person. It is complex and challenging, an ongoing process. It is always wise to err on the side of caution. It is collaborative and relies on effective communication, relies on clinical judgment as well. We should take all threats, warning signs, and risk factors seriously. It asks the tough questions, tries to cover the underlying message. It should be done in a cultural context and it should be documented. These are certain tips for communication during risk assessment. It is very important to be a good listener, to be non-judgmental, to be supportive, and finally build a contract with the person by asking them, will you promise not to do anything harmful till I find help for you? So while performing a risk assessment, we should assess the ideation, the plans, what is the means or methods the person intends to do, and the behavior, the lethality of the attempt, the intent, the risk factors, and the protective factors. So these are some of the questions which we ask to know if the person has ideation, an intent, or a plan. These are some of the risk factors, and potentiating risk factors being unemployed or recent financial difficulties, divorced, separated, widowed, social isolation, prior traumatic life events or abuse, previous suicide behavior, chronic mental illness, and chronic debilitating physical illness. Protective factors can arise from the individual himself, the family, work, or community. It can be internal or external. Internal protective factors being ability to cope with stress, religious beliefs, frustration tolerance, and external protective factors being responsibility to children or beloved pets, positive therapeutic relationships, and supportive relationships. And we can elicit protective factors by asking 3 simple questions. What keeps you going during these difficult times? What are your reasons for living? And what do you rely on during times like this? Coming to disposition and plan. So after doing a risk assessment, we need to triage the patient. We need to see who is at high risk, and that patient should be sent to an emergency psychiatric evaluation. If the patient has moderate risk, further evaluation is needed, but it is not imminent. And if the patient is low risk, how it can be managed. So if the person is of high risk, persons with depression or other pre-existing psychiatric illnesses, those who have had recent recurring events, those who don't have any protective factors, and those who have made a lethal attempt, any recent suicidal attempts, and recurring thoughts about suicide fall under high risk. And for such patients, we need to admit them to a psychiatric setup immediately and remove access to methods and close supervision by a confidant. For people who fall under moderate risk, they might have multiple risk factors with few protective factors. They might have ideation with a plan. For them, admission may be necessary. We need to develop a crisis plan and do frequent check-ins by a confidant. For those with low risk, they have few risk factors and strong protective factors. They have just thoughts of death without any suicidal plans, suicidal behavior, or any attempt. They might require outpatient referral to a mental health professional within the next 7 days. So how to refer? We need to explain the need for referral to the patient, get permission from the same from the individual who is at risk. And we can make use of the available resources like family, friends, relatives, colleagues, or other healthcare professionals. We need to arrange for an appointment and inform the hospital or the psychiatrist about the person at risk. We need to ensure that the person has reached the referral hospital. And it is important to contact the person after consultation and maintain periodic contact and follow-up care. So once a person reaches the mental health professional, he will be evaluated by a comprehensive mental health evaluation and risk formulation. So the mental health professional formulates, asks what is wrong, how it got that way, and what can be done about it. So we analyze the biopsychosocial factors under various headings such as predisposing, precipitating, perpetuating, and protective factors. So this is a formulation matrix which enumerates the context under which we can classify the person's risk factors and protective factors. This is a sample completed formulation of a case scenario which has been taken from website psych database. So which shows a person who was at risk of suicide and categorized the predisposing, precipitating, perpetuating, and protective factors. Okay. Once the person has been evaluated by a mental health professional and he has been formulated, and further actions will be decided based on the risk. So follow-up care can be done even at the primary level. So first follow-up should be done closely by 2 weeks after discharge from the hospital, and the frequency of follow-up should be decided based on the clinical status of the patient. During follow-ups, what should be done? We should ensure compliance to treatment, should inquire about the return of the person to his biological, sociological, and occupational functioning, and monitor for suicidal thoughts, plans, death wishes, and monitor for depressive symptoms or auditory hallucinations. If there are any severe depressive or psychotic symptoms or suicidal plans, it is important to liaise with the DMHP or Medical College Hospital psychiatrist for referral and further care. Next comes safety planning. So we need to help the patient create a list of resources, distraction activities, and emergency procedures in the event they are experiencing suicidal thoughts. It should be a personalized attempt, and we need to recognize patients' own warning signs and triggers for suicidal thoughts. We need to elicit their coping strategies. We need to organize their social contacts and emergency contacts and create backup plans and reducing access to means. So lethal means safety counseling should be done. Lethal mean is any object that the person may use to attempt suicide. It can be pills, poisons, firearms, ropes, belts, knives, and other objects. While it is not always possible to prevent someone from attempting suicide, reducing the access to lethal means can reduce the possible lethality of an attempt, and it is just a temporary method, and it should not be taken up in the long term. In lethal means safety counseling should be personalized according to the cultural and occupational circumstances as well. Some of the common methods to reduce access to lethal means are temporarily removing sharps or firearms from the home, limiting access to potentially fatal medications, removing knives or ropes from home, locking up household cleaners or other poisonous products. So assessing suicide risk in special population, alcohol and other substance use disorders have a higher suicide rates compared to normal population, and opioids and heroin and cannabis users have a higher risk as well. And previous suicide attempters is the strongest predictor of completed suicide. They have a 54-time higher mortality risk for suicide. The first year following the attempt appears to be the most critical one. So coming to the pediatric and adolescent population, and we need to screen with the head SS or the shades, which was given by Ginsberg, which assesses 8 key domains. The geriatric age group, age 85 or more, are 5 to 6 times more prone to suicide compared to the general population. Bedridden, medical illnesses, and dementia make them more prone, and more male elderly compared to females. It is highest in the first 24 months after the death of the spouse, and living alone, loneliness, overdose of medications which they have been already taking, denial of suicide attempt when asked if they committed suicide after being found in the semi-conscious state are all common in elderly age group. And chronic physical health problems, malignancy, neurological disorders, chronic pain, liver diseases, male genital disorders, and arthritis are seen to have a higher risk for suicide, and elderly are particularly prone for subsyndromal depression, which is commonly missed. And LGBTQ+, the marginalized populations and gender minorities is also more prone for suicides. So coming to government helplines aimed at suicide prevention, 104 helpline has been functional for almost 10 years, and TeleManus 14416, which was launched last year in Tamil Nadu as Natpudan Ungalodu Mananala Sevai, has 2 tiers. where the calls are first attended by the counselors who are trained clinical psychologists who escalate the calls to the mental health specialist after screening the high-risk patients. And the mental health specialist liaise with the primary healthcare and DMHP services to refer the patients. So, yes. So the nation's suicide prevention strategy was the first policy in India, which was created in November 21, 2022 to make suicide prevention a public health priority. It aims to reduce the suicide mortality by 10% by 2030 compared with 2020 by effective surveillance mechanisms through district mental health programs in all districts and integrating a mental well-being curriculum in all education institutions. Other government programs which are aimed at suicide prevention are satellite clinics and outreach programs through DMHP and mental health awareness and Manam program. So the carry home message which I would like to give is that primary care is an ideal setting to screen and assess risk of suicide, where we can offer primary, secondary as well as tertiary prevention. Frequent visitors to healthcare, chronic medical conditions, those who have high risk social and economic factors, substance use, pre-existing psychiatric conditions are all at high risk, and majority of the people welcome being asked about thoughts of self-harm. Simple brief tools such as ASQ and CSSRS, the Columbia Rating Scale, might be helpful. Constant liaison between primary care practitioners and psychiatrists is very important. We need to educate paramedical staff and train the primary care practitioners on warning signs of suicide. Follow-up care is essential for long-term prevention, and suicide risk assessment is not a cross-sectional process, rather it is a longitudinal one. And I would like to conclude by comparing primary care physicians to a lifeguard and the mental health services to a swim coach in the prevention of suicide. Thank you.
Better. Okay, then. Thank you. Thank you.
Yes.
Sir, over to President, sir.
Yeah, very good presentation by both the speakers. And today we have a very good attendance also. So the good attendance, more than 85 people joined for the today's webinar. It's deeply encouraging. And the chairperson and the moderator has done a good job. Thanks for all scientific community members. I'll meet you all in the next Enrich Webinar. Good night. Thank you. We have finished on time. Thank you. Thank you both the speakers.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you,
Thank you, sir.
Thank you,
Thank you,
eastwestpharma, for the invitation as well as for the Zoom link. Thank you, Naveen.
Thank you, sir. Thank you so much.